Hello guys, so today we will be covering STIs as per the Canadian Public Health Guidelines. So the tips for screening, treatment and follow-up on the bacterial sexually transmitted bloodborne infections. So what you need to know. So reported cases of sexually transmitted bloodborne infections in Canada are increasing since 2019, and the most common STI is chlamydia trachomatis, and then the second one is Neisseria gonorrhea, third one is syphilis. So among females age 15 to 39 years old, and 15 to 29 years old, STI is common. So normalize discussion about sexual health and offer sexually transmitted bloodborne infections screening to sexually active people as a part of routine care. Screening is an opportunity to discuss transmission, signs, symptoms, and risk reduction and preventive strategies. Undiagnosed and untreated STI can lead to serious complications like PID, epididymoarthritis, and adverse pregnancy outcome. So, what are the guidelines to screen for STIs in Canada? So, in Canada, you need to know that for guidelines, you need to annually screen people who are less than 25 years old and are sexually active. Okay, so individuals with less than 25 years old and they're sexually active, annual screening is recommended. Gay, bisexuals, and other men who have sex with men, so sexually active men with men, annual screening for STI, and transgender person STI screening. So there are three recommendations. The three people eligible for STI screening annually, those are less than 25 years, sexually active, men sex with men, and transgender patient. So offer screening to people who are more than 25 years old based on the risk factors. So what are the risk factors? So we see there is asterisk with risk factors for STBBI is sexually transmitted bloodborne infection. Acquisition include but are not limited to previous transmitted infection diagnosis, new sexual partners, multiple or anonymous sexual partners having an STI or condom-less sex or sex while under the influence of alcohol or drugs. So these are high-risk patient. Even if the patient is more than 25 years of age, you need to screen the patient for STI. Now, offer screening routinely during pregnancy. So we usually screen patients who are pregnant. First of all, we screen for chlamydia, trachomatis, and Neisseria gonorrhea. First screening in the first trimester or first prenatal visit, and then in the third trimester. Let's say a patient who has not presented in third trimester for STI screening, we need to screen that patient during the labor. So screen during labor if no prenatal screening has occurred. So they might give you a case with where a patient has not come up or is a refugee, is an immigrant, has not seen you before, is coming in for a labor. What you gonna do? You're gonna test her for STIs, chlamydia and gonorrhea, both of them. And or third trimester screening did not occur. Maybe a patient might have not come up for an appointment, so we need to screen her during the labor then. Or follow up for positive results were not completed. So again, screening for STI in labor. And then for syphilis, screen in the first trimester or at a first prenatal visit, and then you need to screen at 28 and 32 weeks of pregnancy, during labor in areas experiencing outbreaks, and for people at an ongoing risk factors. Risk factors were condomless sex, new partners, previous STI, multiple sexual partners. These are all risk factors for screening for STIs. Okay, so these are the eligible population: less than 25, transgender, men sex with men, pregnant female, first and third trimester or in labor, and then high risk population on who are 25 years and more but with a high risk factors. Okay, so more frequent screening may be appropriate for those with ongoing risk factors for STI. So STI are often asymptomatic. STIs are often asymptomatic. If a patient is presenting, let's say, with a urethral discharge, you're not just gonna screen them for gonorrhea. You will also gonna screen them for chlamydia, syphilis, HIV, but you need to ask the patient before you do that in Canada. Okay, so there are three different STIs that we're discussing here: chlamydia, Neisseria gonorrhea, and syphilis. So what are the samples that we're gonna send? Urine is the most appropriate test that we usually do in the clinical practice. We send the urine for nucleic acid amplification testing, that is NET testing for chlamydia trachomatis, and NG, which is Neisseria gonorrhea. We can also take swabs for urethral, cervical, vaginal samples. We can take rectal samples, pharyngeal samples. But rectal and pharyngeal we take in case the patient is presenting with a scenario where they have, omitted pharyngeal, like oral sexual intercourse or rectal sexual intercourse. And we usually send urine for nucleic acid amplification test. For syphilis, we need to send blood, which the laboratory will perform serology using algorithm combining non-treponemal and treponemal testing. Okay, so offer HIV testing when screening for other STIs. Tips are: NAT is highly sensitive and test of choice when screening asymptomatic individuals for CT and NG. Preferred specimens for NAT are first void urine or self-collected vaginal swab. Collect pharyngeal and rectal specimen for individual with history of performing oral and receptive anal intercourse respectively. That's what we have discussed so far. Check with your lab for availability of NET for rectal and pharyngeal specimen. Collect specimen for both chlamydia and Neisseria during high rates of co-infection. When NG, Neisseria gonorrhea, is suspected, collect specimen for NAT and culture. Culture permits antimicrobial susceptibility testing to guide treatment. Ideally, collect specimen prior to empirical epidemiological treatment. Tips: testing algorithm may differ according to provinces, but that's how you do it. So, what if a person has come out positive for either one of them? So, for chlamydia, prefer treatment in the absence of contraindications, allergies, and pregnancy. Three major things that we need to consider: pregnancy, allergies, and contraindications. No contraindications, not pregnant, no allergies, go ahead. Chlamydia positive, even if not positive, you need to empirically give treatment for with azithromycin 1 gram per oral single dose, or doxycycline 100 milligrams BID for 7 days. Doxycycline 100 milligrams BID for 7 days, or azithromycin 1 gram per oral stat dose. Okay. For anogenital pharyngeal infection, ceftriaxone 250 milligram in intramuscular single dose plus azithromycin 1 gram per oral in a single dose. Or if anogenital infections, then cefixime 800 milligram per oral in a single dose plus azithromycin 1 gram per oral in a single dose. So we are either giving ceftriaxone or we are giving cefixime, but cefixime is not a preferred treatment for patients with men who have sex with men. Okay, so ceftriaxone with azithro, yeah, or pair cefixime with azithromycin, cefixime or ceftriaxone. Okay, so for syphilis, for infectious syphilis, primary, secondary, or early latent, we need to give long-acting benzathine, penicillin G 2.4 million units intramuscular single dose, or latent long-acting benzathine, penicillin G 2.4 million units intramuscular weekly for 3 doses. For latent, we are giving 3 doses on a weekly basis, but for primary, secondary, or early latent, we are giving stat dose of 2.4 million units. Okay, so tips for Neisseria gonorrhea infection: always use combination therapy to prevent resistance and treat possible co-infection, chlamydia co-infection. So for chlamydia co-infection, we are giving azithromycin 1 gram per oral stat dose along with ceftriaxone or cefixime. The use of two antimicrobial with different mechanism of action may improve the treatment efficacy and prevent or delay the emergence or spread of the resistance. Neisseria gonorrhea, ceftriaxone 250 milligram intramuscular in a single dose plus azithromycin 1 gram per oral in a single dose is recommended treatment for pharyngeal Neisseria gonorrhea or for men with who have sex with men. Okay, so ceftriaxone with azithromycin. Cefixime we are not giving for those patients with men who have sex with men. Okay, for chlamydia infections, consider using azithromycin if poor compliance is expected. So there are two different options for chlamydia. We saw that it was doxycycline for 7 days, 100 milligram BID, yeah, or azithromycin single dose. So azithromycin single dose is good for patients with poor compliance. Individuals and their partners should abstain from sexual contact until the completion of the multiple dose treatment or for 7 days after the single dose treatment. So for 7 days, it is better to avoid sexual intercourse. All partners who have sexual contact with individuals within 60 days prior to specimen collection or onset of symptoms should be tested and treated. So once we have the positive results, we need to contact trace and we need to let the patient know that their partners also needs the treatment and testing. Okay, so 60 days prior or during the symptoms onset, if they have sexual contact with anyone, they need to come and get themselves tested and treated. Okay, And to avoid, abstain from sexual activity for next 7 days after the treatment. And we go treat the patient who are coming with gonorrhea. We have to go treat them with azithromycin as well to avoid drug resistance and to cover for chlamydia as well. Okay. So in tips for HIV, inform individuals of potential Jarisch-Hershmer reaction to penicillin treatment. They may have this reaction, let them know. And also penicillin desensitization for individuals with penicillin allergy, followed by treatment with long-acting penicillin G. So very important thing, if a patient is resistant to penicillin G, we need to desensitize them and we have to give penicillin G. There is no satisfactory alternative treatment to penicillin for treatment of syphilis in pregnancy. Okay, so there is no other alternative treatment. Individuals and partners should abstain from sexual contact for 7 days after treatment. So that's similar to what we have learned. All sexual partners' perinatal contacts should be tested and treated according to the individual stage of infection and date of specimen collection or onset of symptoms. Primary for 3 months, secondary 6 months, early for 1 year, and latent tertiary individuals, long-term sexual partners, and children as appropriate. Follow up. So we do not generally do follow up, test of cure again. That is TOC is a test of cure. But in chlamydia, we have to do test of cure in 3 to 4 weeks after completion of treatment. When? Only when the patient is compliance to treatment is suboptimal, unresolved or persistent symptoms are present, alternate treatment regime was prescribed, individual is pregnant or prepubertal. So we have to do test of cure after 3 to 4 weeks of chlamydia trachomatis, where we check for compliance. We know the patient is not compliant. We know the infection might have unresolved, or the symptoms are still present. Alternative treatment regime was used, or individual is pregnant or prepubertal. We have to do test of cure after 3 to 4 weeks. For gonorrhea, test of cure is recommended using culture or using NAT. If we are using culture, we have to do it in 3 to 7 days after completion of treatment, and if we are using NAT, then we have to do it 2 to 3 weeks. For chlamydia, we were doing 3 to 4 weeks, but for gonorrhea, we are doing it in 2 to 3 weeks, and if we are doing culture, we have to do it in 3 to 7 days. Test of cure is of particular importance when treatment failure and resistance to Neisseria gonorrhea is suspected, compliance to treatment is suboptimal, unresolved or persistent symptoms are present, alternative treatment regime was prescribed, individual is pregnant or prepubertal, pharyngeal infection was detected. So these are the cases where we need to do test of cure. So you may have a scenario where they may ask you that when are you going to do the test of cure. So if patient is pregnant, treatment is suboptimal, alternative treatment was used, patient is still symptomatic. In case of gonorrhea specifically, if there was a pharyngeal infection detected, or if there is treatment failure. Okay, so we have to do test of cure. Culture 3 to 7 days, NAT 2 to 3 weeks, for chlamydia 3 to 4 weeks. Okay, and for syphilis, indication for post-treatment monitoring and follow-up serology: infectious syphilis, primary, secondary, or early latent, 3, 6, and 12 months for test of cure. Latent and tertiary syphilis, 12 and 24 months. If it was neurosyphilis, 6, 12, and 24 months. Co-infection with HIV with syphilis, then 3, 6, 12, and 24 months, and yearly thereafter. Pregnancy, primary, secondary, early latent syphilis, if at risk of reinfection monthly until delivery, otherwise 1, 3, 6, and 12 months. Late latent at time of delivery, 12 to 24 months. I know this is very overwhelming, but this chart is very important to remember. When are you going to do the test of cure? So as a physician in Canada, you need to remember that the test of cure for syphilis, when are you going to do? If it's infectious, if it's latent, if it's neurosyphilis, if it's co-infection with HIV, if the patient is pregnant, when are we doing the test of cure? So the tips is, when test of cure is indicated, specimen should be collected from all positive sites. Test of cure using NAT should be performed at recommended post-treatment interval to avoid detection of the residual genetic material. So for chlamydia, it was 3 to 4 weeks, and for gonorrhea, it's 2 to 3 weeks, right? In addition to test of cure, repeat screening is recommended 3 to 6 months post-treatment due to risk of reinfection. And then after the test of cure, you will do routine screening is recommended 3 to 6 months post-treatment due to risk of reinfection. For syphilis, post-treatment serology is used to assess the treatment response. Consult a colleague or specialist experience in syphilis management if serological response to treatment is inadequate. So these are the guidelines for health professionals from Canadian websites. So make sure you learn this because this is very, very important, and it's something that is different from Toronto notes. Okay, so yeah, that's about it. Now next we'll cover about HIV.